University of Gothenburg and UCL and University of Wisconsin. And I am here with my co-chair.
I'm Niels Reiner on behalf of Dr. Laura Jonkman, who unfortunately couldn't be here, but wishes she was, because indeed this is the best session of the of the conference. I'm from the Amsterdam UMC.
And we will start with an important announcement, because this is a CME session. So if you want your CME credits, Alex is in the audience. There, she waves now. So then you just go to her and get your signature. And with that, we should start, right?
Yes.
Then I have the great pleasure to introduce the first speaker, Dr. Sibin Lim from the Mayo Clinic, who will talk about tau PET overlap index and neuropathological findings in his cohort. Please.
Okay, thank you for introducing Halik. My name is Sibin Lim. I'm from Mayo Clinic, Rochester. Good morning, everyone. Today I'm going to talk to you about tau PET overlap index correlates with neuropathology findings in early Braak stage. This is disclosures for this study. Okay. In the brain, if we get age, if we undergo dementia, the tau in microtubule is going to be lost from microtubule. It makes neurofibril tangle, we call it NFT. This NFT has 4 different status for their lifespan. So there are many methods to stay in brain tissue to look into neurofibril tangle maturity. This research will be very important to understand the mechanism of tauopathy in various dementia diagnosis. Otherwise, in terms of molecular image of tau PET image is very important to look into brain or tau accumulation. There was the study to investigate association between tau PET and tau neuropathologic findings. The study found that the tau PET signal was associated with Braak stage above 4. Based on the tau PET image, tau PET overlap index was developed, which is the method to show spatial consistency by overlapping baseline scan and follow-up scan. The overlap index is the ratio between number of foci over threshold in baseline scan and number of overlapped foci between baseline scan and follow-up scan. The overlap index OI in this study, OI was more sensitive to tau signal evaluation and longitudinal change than standard RI measure. However, although OI show their potential to sense tau signal, it still remains various ways to validate tau PET OI. So in this study, we tried to validate the tau PET overlap index with neuropathologic diagnosis at autopsy, and evaluate the tau PET overlap index associated with IHC ARG at autopsy visually, and evaluate the tau PET overlap index to detect in terms of early Braak tangle stage. For this study, 57 participants were included who underwent serial tau scan and autopsy. The tau PET overlap index was adopted for validating tau PET OI potential. We used intensity threshold 1.3 to extract the cluster map, both baseline scan and follow-up scan. Based on those cluster map, we extracted overlap cluster mask image, which was used for visual analysis for comparing with IHC and ARG result. First, we conducted a meta-ROI analysis by primary neuropathologic diagnosis group. AD pathologic diagnosis group were divided by 3, AD high, AD intermediate, AD low, based on the autopsy report. Comparing OI and LCVR, OI can capture the tau signal in AD group, especially the AD lower group. Interesting thing is OI can capture tau signal in other pathological diagnosis group compared with LCVR result. So I brought example of tau PET overlap index image for comparing IHC and ARG result. There were 3 different AD cases, an FTDP 17 case and FTRD tau CBD case. As you can see, overlapped tau voxels were detected as corresponding to IHC and ARG result visually. Small overlapped tau voxels were shown in the AD intermediate case, although this case OIN and SCVR were negative. Also, I brought the different pathological diagnosis example. This case are all OI positive only cases. As you can see, overlapped tau voxels were detected as corresponding to IHC and ARG result visually. So one of interesting is that OI can capture tau signal of 4 tauopathy individuals in some of white matter area as corresponding to yellow arrow. This is the FTLD tau CBD case. As you can see, overlapped tau voxels were detected in gray matter area as well as in some of white matter area as corresponding to yellow arrow. This is the CBD case, just the same. This is the PSP case. So I think OI can capture the tau signal of 4 tauopathy individuals. So these are the results of OI analysis with Bragg-Tangle stage in terms of neuropathological diagnosis and neurofiber tangle level. Overlap index and SUVR were derived from insulinal cortex. A is showing OI SUVR data by Bragg-Tangle stage in terms of pathological diagnosis group. As you can see, in terms of early Bragg-Tangle stage, OI can capture tau signal in terms of early Bragg-Tangle stage. And B is showing OI SUVR data by Bragg-Tangle stage in terms of insulinal cortex neurofiber tangle level. This is the same data as previous one, but it has a different marker type, insulinal cortex neurofiber tangle level. As you can see, it also shows that OI can capture tau signal in early Bragg-Tangle stage. So I brought an example of overlap index image with Bragg-Tangle stage in insulinal cortex area. These cases are all OI positive only cases from Bragg-Tangle stage 0 to 3. As you can see, overlapped tau voxels were detected as corresponding to IHC and ARG result. At the same subject in different area, posterior hippocampus area, as you can see also OI can capture tau signal in early Bragg-Tangle stage. So tau PET overlap index has also association between with cognitive scores of memory function in terms of pathological diagnosis group. In summary, tau PET OI improves in detection of tau signal compared with SCVR in AD spectrum, especially AD low group. Tau PET OI can detect neurofiber tangle level in various pathologic diagnosis group. Also, tau PET OI can detect the tau signal in the 4 tau pathological diagnosis group, and tau PET OI correlated with neuropathologic IH findings with the various pathological diagnosis group as well as early Bragg-Tangle stage. So I would like to sincerely thank Dr. Low and Dr. Murray for guidance of this research, and I would like to thank Dr. Min, Dr. Lee, and Dr. Moloney and Sujala for supporting of this research. Thank you for listening to my presentation.
So for the next speaker, I would like to introduce Emma Commans from the Amsterdam UMC.
Thank you for the introduction. Great to see so many of you on the final day. So I would like to present to you the novel result that we have on our project entitled Neuropathological Correlates of Age and Sex Differences in floor tau spear PET. These are the disclosures of the Alzheimer's Center, but I personally have nothing to disclose. So tau neurofibrillary tangles are a key pathological hallmark of Alzheimer's disease, and we can visualize and quantify them using PET. And previous studies looking into the neuropathological correlates of floor tau spear have shown that suprathreshold tau PET generally corresponds to the presence of postmortem Bragg5-6 pathology, of which one of the figures you've also just seen in the presentation before me. So if you have a positive tau PET scan, this generally reflects the presence of widespread tangles in the brain. Previous tau PET studies have also shown that in amyloid-positive participants with cognitive impairment, older age and male sex is associated with lower tau PET retention. And therefore, a negative tau PET scan is more often observed in older and or male participants as compared to young and or female participants. And this may have implications for their clinical diagnosis or inclusion into trials, because that's, amongst others, what we use tau PET, or what we can use tau PET for. If we look into autopsy studies, then they have also shown that lower neurofibrillary tangle density at autopsy is associated with older age at death and male sex. And therefore, I think a question is whether these tau PET negative older and or male individuals, whether they truly do not harbor any BRCA5/6 pathology in their brain, or whether it is present but at lower densities, and therefore maybe the lower density is below the PET detection threshold, and that's why we're not capturing it using tau PET. So our aim was to investigate the neuropathological correlates of age and sex differences in fluoro-tau superior imaging using independent PET-only, autopsy-only, and PET-to-autopsy analyses. We first aimed to provide proof of concept evidence that there are age and sex differences in fluoro-tau superior imaging in specifically amyloid-positive individuals with cognitive impairments. We aimed to investigate whether we would find similar effects when we look at an autopsy cohort. And then we aim to determine the correspondence of antemortem tau PET to postmortem BRCA5/6 pathology and whether this varies by age and sex. And then finally, we aim to investigate these age and sex effects on both antemortem tau PET and postmortem neurofibrillary tangle density in the same individuals. So for the PET-only cohort, we included participants from the Amsterdam Dementia cohort, from ADNI, Biofinder 1, and different studies from Eli Lilly. They all had MCI or dementia, and they all were amyloid positive, and all underwent fluoro-tau superior PET imaging, from which we calculated temporal meta-ROI SUVR. For the autopsy-only cohort, we included participants from the Banner Health cohort in Arizona. Also, they all had MCI or dementia, and they all were amyloid positive by means of moderate or frequent CIRAD scores. We only included participants that had both BRCA staging available and the neurofibrillary tangle density measurements. And for the PET-to-autopsy cohort, this is a much smaller cohort because it's quite rare. We included participants from the Eli Lilly A16 end-of-life study, from the Amsterdam Dementia cohort and ADNI, whom underwent fluoro-tau superior PET imaging during life, and then died and donated their brain and went to autopsy after. And we only included participants that had BRCA staging available. A subset of these participants, only those from the Eli Lilly study, they also had measurements of neurofibrillary tangle density scores available. And for both fluoro-tau superior imaging in the PET-only cohort and the PET-to-autopsy cohort, we defined a positive tau PET scan based on a threshold of 1.36 SUVR. This is a threshold defined in previous studies and has been applied to the cohorts that we included here as well. So here you can see the table of demographics. For the PET-only cohort, we included participants of about 72 years of age, and about 53% were male. In the autopsy-only cohort, we include participants of about 83 years of age, and about 55% were male. And in the PET-to-autopsy cohort, we included participants of about 81 years of age, and 53% were male. And there was a very short median PET-to-postmortem time interval of 2.6 months. So first we aim to look into, provide proof of concept evidence that there are age and sex differences in tau PET. And what we found is that older age is associated with a lower likelihood of being tau PET positive, shown in A, and also with lower continuous values of tau PET SUVR, shown in C. We also found that male sex is associated with a lower likelihood of being tau PET positive, shown in B, and also with lower continuous values of tau PET SUVR, shown in D. So overall, these results are very consistent with what we know from existing literature, and they provide proof of concept evidence that there are age and sex differences in fluoro-tau superior imaging in specifically amyloid-positive symptomatic individuals. So we next wanted to see whether we would find similar results in an autopsy-only cohort. Here we found that older age is associated with a lower likelihood of BRCA5/6 pathology, shown in A, and also male sex is associated with a lower likelihood of having BRCA5/6 pathology in your brain, shown in B. One important thing to take in mind is that the BRCA staging system is relatively crude, so people can be assigned BRCA stage 5 or 6 when only a single tangle or very few tangles are present in BRCA5/6 regions. So we wanted to next look into individuals that have BRCA5/6 pathology and then understand whether age and sex still affect the amount of tangles that are present in the brain. So when we restrict our analysis to individuals that have BRCA5/6 pathology, we observe this quite strong effect between older age at death and lower tangles in the brain, even though they all have BRCA5/6 pathology. For sex, this effect was not significant, although there was, the direction was favoring an association between male sex and lower neurofibrillary tangle density in the presence of BRCA5/6 pathology. So overall, these results were, tau PET results were largely supported by this independent autopsy cohort. So next we wanted to investigate the correspondence between antemortem tau PET and postmortem BRCA5/6 pathology and understand whether this varies by age and sex. So in these plots you can see antemortem tau PET SUVR on the y-axis, and on the x-axis you can see the BRCA stage separating BRCA1 to 4 from BRCA5 to 6. And the dashed line represents the threshold for tau PET positivity, and then the plots are stratified based on median age at death at 83 years and based on sex. And you can see that all individuals that are tau PET positive, so that fall above the tau PET threshold, they also have BRCA5/6 pathology in their brain. So the specificity and the positive predictive value for tau PET for detecting BRCA5/6 pathology is really excellent. However, if you look at the sensitivity and the negative predictive value, we do see that individuals that are older or male, that they more often can have BRCA5/6 pathology in their brain, but actually fall below the threshold for tau PET positivity. And if you look at the sensitivity, for example, at younger ages, below 83, it's 92%, but at older ages, it's 42%. So the sensitivity and the negative predictive value, they really seem to decrease at older age and in male sex. This median split is quite arbitrary, of course, for age, so we also stratified the cohort based on other age thresholds, and there we see that the sensitivity and the negative predictive value, they kind of start to decrease after the age of 70, 75. So next we wanted to know whether those cases that have BRCA5/6 pathology but fall below the tau PET threshold associated with older age and male sex, whether they also have lower tangles in their brain, so a lower tangle density. So in the same PET to autopsy cohort, restricting to people that have BRCA5/6 pathology, we found that older age at death and male sex is associated with lower tau PET SUVR. And in the same individuals, it was trend level, but we also found an association between older age at death and lower tau tangle density in the brain. For sex, again, this effect is not significant, although the direction does favor an association between male sex and lower tau tangle density in the brain. We also looked at whether age and sex modify the association between tau PET and neurofibrillary tangle density, but these interaction models were not significant, although it's also limited by a low sample size. So in summary, older age and male sex are associated with a lower likelihood of tau positivity and lower tau load in symptomatic individuals that have amyloid pathology, both in PET cohorts and in autopsy cohorts. We also found that tau PET really has a truly excellent specificity and positive predictive value for identifying the presence of postmortem BRCA5/6 pathology, but the sensitivity and negative predictive value does seem to decrease at older age and in males. And tau PET is closely associated to the density of neurofibrillary tangles in the brain, and this may also account for its lower sensitivity to detect low-density BRCA5/6 pathology in frequently older and male individuals. So I would like to thank my colleagues from the Alzheimer's Center, also all collaborators that contributed to this project, and especially my supervisor, Rick Ossekoppel, and happy to take any questions after. Thank you.
Thank you. Please remember to take notes of your questions, and we will have a wonderful session with questions after all presentations. And also welcome to submit online. So then it's my great pleasure to introduce Dr. Stamatia Karagiani to you, and she, from the University of Gothenburg, she will present on phospho-tau217 relationships with neuropathologic change. Please.
Flattered, but I'm not a doctor yet. But thank you.
Just
started. So, hi. And yes, so I'm Stamatia. You can call me Stam. I'm from Gothenburg University. And today I will show you really interesting findings about the performance of p-tau217 across ADNC. And yes, before starting, this is the Niagara Falls. I went yesterday. It's my picture. It's amazing. Go. And nothing else to disclose, whatever. And yeah. So why ADNC in vivo detection is important? Because one, it helps in early detection, in disease staging basically, and in clinical trials eligibility. So also Emma showed really nice fluoroscopy PET imaging with the visual reads of the FDA. It's the only approved way that we can see the high ADNC, and that's important. But it's costly, it's not available, and at the same time, it's a bit time consuming, and that's why we're really happy, because now we have the first approved plasma. So yay, Lumipulse, the ratio p-tau to 17, a beta 42, that can help to identify amyloid positivity and reduce reliance on PET scans. Is it that true? Well, our question is that simple. How well the ratio, because now we have the approved one, back then with the abstract it wasn't, can perform to detect ADNC, also in autopsy, but also in vivo with the visual reach of fluorotocipir. And how we did this? Of course, using NADNI. So autopsy data, 119 people, and we have over 600 with fluorotocipir. All of them, the scans, they went over 3 readers to assess if they're positive or negative, FDA approved. And then, of course, when we are going for the plasma, Adni did us the favor and she has Lumipulse, so we can finally assess how does it perform, the approved one for ADNC, using the predefined cut points. And predefined, I mean the approved ones for the ratio, and for the p-tau and the a-beta ratio, we just use the ones that they propose from ADI. Also, we use A4, but because they are using a different essay, we will not include here the results because of the 10 minutes presentation, but if you're interested, let me know. So, statistical analysis, easy, busy, lemon squeezy, autopsy versus p-tau, fluorotocipir versus p-tau, CU, CI, and the analysis. So, I want to start with the results. So, post-mortem, already we can see that it has a really good, indeed, the ratio can detect the high ADNC versus the no, low, intermediate. And if we see the box plots, you can see that the stage 3, which means high ADNC, all of them, they will be correctly identified. The interesting part is what happens to the other one. So, yes, identify, congrats, plasma, but when we go to no, then we see 25% of false positives. And you will say, come on, that's not too much, but still exist. And when we go to the intermediate ones, then we see a bit of discordance. So 10% of negative for the low, 77 for the intermediate as positive, but you will say, okay, maybe you're too much. It's okay, and I will agree. It's positive, then it's sensitive. But we have to keep in mind, it's ADNC in ADNI. So that means that it's already in our sample, 2 and 3 are more. We have only 5 people in 0, but still, this means that they had no AD pathology in their brain, and plasma identified something. So I will keep the positivity in my mind, and I will say, yes, it's sensitive, and I will go to the in vivo one to tell me something. So first of all, how we define the ADNC is minus no amyloid, basically, no ADNC, intermediate amyloid positive, tau negative, and both positive is the high ADNC. And already you can see that, again, correctly identifies the high ADNC, while we see a lot of false positives in amyloid negative, and I will come back to this. Because I want also to say that seems that plasma performs better for CI cases instead of CU. So, back to the positivity, sensitivity thing, because I'm optimistic. I would like to check what happens to the preclinical cases. So this intermediate, so amyloid positive, cognitive normal. So if this indeed it is sensitive, I would expect that it would be also good performance. Well, when we checked about this, it's only 50% that would be correctly identified as positive in these preclinical cases. And that's something that makes us questioning, is it indeed good, the approved plasma, for detecting the early preclinical cases that we care so much? Because also when you go to the CI ones, you see 73%. And that brings me back to the false positives. And what I want to say here is, look at this. Amyloid negative, cognitively normal, cognitively healthy. And only 62% they will be correctly identified as negative. Meaning, if this was a sample going for a clinical trial, 39 or something percent would be intermediate positive, going for the next phase probably. So maybe that would happen unless there was PET around. So a lot of info, I know, but we learned something, I think. So p-tau, the approved ratio in post-mortem, yes, correctly can identify high ADNC, but seems poorer for lower and intermediate. And this is also confirmed from in vivo data for high ADNC, correct. When we go to preclinical cases, it doesn't work that much. So approved one, correctly for high ADNC, but limitations in preclinical cases, high false positives, and less reliable in low intermediate. So I would like this as a take-home message, but because I believe that all this is a continuum and every biomarker has a place here, it's good that we have plasma, because without this today, we would not celebrate all this improvement about Alzheimer's. But it's good also to think that maybe the approved one that we have now, the plasma, it's good, but maybe not as good as we would like to say. That's how imaging comes to such a multimodal approach. We need imaging, and that's okay. Don't blame us. So I would like to leave you. Thank all the participants, fellowship for this, I saw the Niagara, yes, group, and of course, Michael Schell for all the support, and of course, Alex Moscoso for teaching me neuroimaging, and all of you for being here today, last day. Congrats, love you. Thanks for the first AIC of me. You made it perfect.
I would like to introduce the next speaker, Yuang Chen, from the Memory and Aging Centers at UCSF.
Thanks for the introduction. We are actually recently transitioned to Mayo Clinic, but I'm also from UCSF. Love for both great institute. And yeah, let's get started. Okay. My disclosure. So I believe the audience in this room are quite familiar with this compound, photosapir. It is probably the only FDA-approved PET tracer for detecting tau, and it is widely used. And from previous study, we know for the fact that it can detect AD tau very well, not so much for the non-AD tau, for repeated tau. But even so, we are still seeing some unexpected signal retention in AD area that is not known to have AD pathology in histology. And for cases that have no tau pathology at all, like the TBP43 type A case, we are still seeing a high level of signal retention. We don't know exactly why, and study have been made the effort to understand the cause since it may confound diagnostic. Here we are proposing a method that we developed throughout the years for the voxel and voxel correlation to add relevant information in this problem. We are mainly testing two off-target binding agents, iron and MAOB, since previous study suggests that iron accumulate in patients not only with neurodegenerative diseases, but also in healthy control during normal aging. At the same time, normal aging also correlated with the positivity of photosapir PET signal. And in addition, the autoradiography result also shows some linkage between MAOB to photosapir signal. So to conduct this study, we collected 5 cases. We have one AD, one PSP, CBD, FTLD MAPT case with S305I mutation, this representing the non-AD tauopathies. And lastly, we have a TDP type A case to representing the no tauopathy neurodegenerative disease. So we select the representative region of interest in these cases based on the positive photosapir signal, thresholded at 1.2 SUVR by our clinical team without the previous knowledge of the pathology. There are brain slabs, what we call slabs, and hemisphere that is sectioned at the coronal plane. There will be 2 for AD and 1 slab for the rest of the cases. And these slabs are then further sectioned at 160 micron thickness in a serial continuous fashion. And these neighboring slides are then stained with immunohistochemistry for CB13, staining phosphorylated tau. We have the Prussian blue for the iron staining. And lastly, we have MAOB staining as well. And scanning are done at a Z-level stacking with multiple focus. So for those who are interested in detail of the method, is published already. Basically, we're utilizing a convolution neural network-based model segmentation to quantify our phosphorylated tau and MAOB. For staining that have less amount of background, like ferric iron, we're then utilizing a Weka segmentation toolkit for quantification. All quantification are done at the micrometer scale. After that, we then send this data into our voxel reconstruction pipeline for reconstructing the voxel in 1 cubic millimeter space to match the MRI voxel size. Then we put all this data into our registration pipeline involving landmark and nonlinear registration to map our histological data to our MRI and PET scan in voxel-to-voxel fashion. And lastly, for statistical analysis, we are first running the bivariate experiment correlation followed with multiple linear regression modeling to study the relative contribution of each of the biomarker to photosynthesis signal. And all tests are run through a variance inflation factor for checking the collinearity. So what we learned from our AD result is that tau pathology is really the main contributor in both regions that we have for Alzheimer's disease. Iron is showing a regional variation between the two slabs. We believe that is due to the various iron accumulation in different anatomical regions within the same tauopathy. More details about it later. And when we combine the two regions in AD into the same analysis, we are seeing a positive correlation of the phosphorylated tau, which is mainly contributing to the photosynthesis signal, followed with the iron as a second. And MLB is showing a non-significant correlation to the photosynthesis signal in AD. It gets a little bit more complicated when we're looking at the 4-repeated tauopathy result, when we are seeing that iron and MAOB have a high significance in correlation comparing to phosphorylated tau in photosapir. And when we are looking into the voxel distribution of these cases, we can capture that there are higher white matter signal in the photosapir in PSP, and also the similar phenomenon seen in the MAOB, but not in the phosphorylated tau or iron. Similarly in MAPT as well, validated by the box plot on the left. So we wonder what would happen to the correlation when we exclude these white matter voxel and only focusing on the lenticular nucleus, which compose of putamen and globus pallidus, the two known off-target regions. What would the correlation show us? And then is where we can see a lead of the iron correlation and contribution to the photosynthesis signal in both PSP and MAPT case, where here the MAOB is showing a pathological difference between the two cases, showing a significant correlation in MAPT but not in PSP. Now, given the previous result, we would expect a similar trend that we would see in the TDP type A, where there's no tau pathology. And indeed, in both of the hemisphere and lenticular nucleus correlation analysis, we are seeing a similar strength of both iron and MAOB contributing to the photosynthesis signal. So to sum it up, what we learned is that photosapir is a reliable PET tracer for detecting AD tau, though iron and MAOB showing some off-target binding behavior with photosapir is mostly affecting the 4-repeated tauopathies and TDP 43 cases. And more throughout analysis may be needed with this voxel-to-voxel method to further validate if there are any other off-target binding factors that could contribute to the photosapir signal binding profile, since throughout the cases we have a pretty low R-square value in the linear regression analysis. So some of you may have heard about this study in my previous presentation in the past conference, which we are now finished writing the manuscript and ready to publish. But I think it would be worth to mention some obstacles that took us a long time to solve, and also some limitation in the study. So I want to point out that key component of this study is really the image registration, especially when you're doing voxel-to-voxel analysis and multimodality studies, which is very sensitive to any kind of image or data misalignment. Something that you really need to think about at the stage of the autopsy, for example, how to preserve your tissue structure better and reduce the amount of distortion during immunohistochemistry. The second thing is that when comparing data with different resolution, it always involves voxel resampling, which then could lead to information loss inevitably. But we can take some measure to minimize that effect. So for example, when you're constructing your voxel, be mindful about what you try to achieve in terms of voxel size. Don't overestimate or underestimate the voxel size you're comparing to. And also, you probably need to do FWHM matching between the data. And it's better to do it with a mask to limit the calculation of the FWHM so that you don't over blurring your data set. And lastly, I want to acknowledge the fact that there is a PET to autopsy time gap between the data set. And that's probably the reason why we only have like 5 cases, because we want to shorten that time gap as much as possible, since it may affect our analysis. So it used to take us a long time to finish one case. Right now, approximately 1 to 2 weeks per case. So time to press the gas pedal and full throttle, right? So what's next? Well, we are currently doing a QSM MRI study with our histological data. Many of you known for its ability to detect iron, but we are focusing on its capability to detect in vivo tau or amyloid, actually, with its decomposed algorithm. And also, just for the sake of discussion, how about mapping the spatial proteomic data or transcriptomic data to high-resolution MRI? Can MRI signal reflect the gene expression pattern that we see? So lastly, I want to take the final moment to thank all the patient and the family for completing this study, for the valuable contribution, my co-author, my collaborator, and colleagues for the help finishing this study and refine the method. And of course, my mentor, Dr. Leah T. Greenberg. And please contact us. We, as I mentioned before, we recently transitioned to Mayo Clinic from UCSF. Again, both great institutes, so no beef there. And I think we are hiring a postdoc as well. So yeah, please contact us for future collaboration opportunity as well.
And we are on time. This is the first time in my life as a chair that has happened. New experience. It's my great pleasure to introduce my co-chair Niels to you, and we will hear about MRI and postmortem findings. Please.
Thank you for the introduction, and thank you all for staying around for the last session as well. I'm here on behalf of my mentor, Dr. Laura Jonkman, who unfortunately couldn't be here, but like I said, wished she was. I would like to talk to you about our research on MRI measures of neuropathology in neurodegenerative diseases. I have nothing to disclose. So the key concept of our research framework is that instead of focusing on any of these fundamental research domains, like MRI, pathology, and clinical translation, we want to integrate these fields and point our research focus to these overlapping points to truly answer multimodal research questions. And I'm very happy to see these kinds of approaches more and more also this year at AIC. So we do this using standard to advanced MRI approaches, disease-specific and novel pathological markers, and we use a rich disease history of our cases and cognitive and antemortem data, which already gives a hint about our pipeline. But just to tell you about our research statement, it's scaling across MRI and pathology to innovate brain research and translate findings into meaningful and, importantly, clinical impact for neurodegenerative disorders. And we can do this thanks to our unique post-mortem pipeline, which I want to talk to you also a little bit about. So of course we have donor inclusion located in the Netherlands, in Amsterdam. And here we include healthy controls, Parkinson's disease cases, Lewy body dementia, Alzheimer's disease, and frontotemporal dementia. and including also some more rare cases, like, for instance, MSA. Of these cases, especially the AD, we have a multi-year clinical background. We have information of the disease history, also antemortem data, and even genotyping. So what do we do? After the donor passes away, we immediately go for a post-mortem in situ MRI, meaning brain still inside the skull, which is the best way for a clinical translation step. And here we do an in situ 3 Tesla MRI scan, and afterwards also an ex vivo 7 Tesla MRI scan on a subset on one half of the hemisphere. And we collect a series of sequences. And we all do this, or we cap the post-mortem delay under 10 hours. And then at autopsy, we do an anatomical dissection. The left hemisphere we do on cryofixation, and the right in formalin fixation. And we collect about 90 regions of the brain. And this is all under 12 hours. But our average is under 8 hours. And for specific methodologies, we also can do it under 6 or 4 hours. And this allows us to, of course, investigate this brain tissue, do pathological diagnosis and digital quantification. So just to talk a little bit about the use of post-mortem MRI as proxy for antemortem MRI, we have this very interesting case, PSEN1 mutation, that donated his brain. It's a paper, a case study by Biomarkers, which I would invite you all to read. But we did a 4 days antemortem scan and 9 hours post-mortem scan. And what we see is mainly ventricular change. We think that this is due to low pressure or lower pressure of the CSF. But these are all linear changes, so it's very easy to correct for. And then in another study, we looked at cortical volume differences from antemortem to post-mortem. And we saw that within a antemortem to post-mortem interval of 2 years, this cortical volume difference remains under 10%, so quite a good proxy still. And then I want to talk to you about what we do with this research. First of all, my own research, we saw by looking at brain-wide association of cortical volume with amyloid beta quantification histologically, that we saw an increase in association. So higher amyloid beta levels meant higher cortical volumes. And we thought that this would perhaps be due to global swelling to the amyloid plaques occupying brain tissue, or of course recently it has also postulated that there is an amyloid beta mediated inflammatory swelling, which was a quite interesting finding. And we saw that neuroaxonal damage was the most important marker for atrophy. And then when we looked at this regionally, we saw that the hippocampus was unsurprisingly the strongest regional marker for this association. And then we looked at the T1, T2 ratio, a very simple marker, but clinically viable, which was postulated first by Glesser and Van Essen to map myelin in the brain. They looked at this in control cases, and we postulated that as soon as you look at neurodegenerative diseases with a lot of pathological processes, these processes also start to contribute. So it's more of a marker of cortical integrity. And indeed, we see in AD, first of all, a lowering of this T1, T2 ratio. Then if you look in controls, we see that mainly myelin associates. But in AD, we see that other pathological processes also start to associate. So here we validate this simple ratio as a cortical integrity measure. And then a colleague of mine, Alex Wesseling, looked in donors with limbic predominant age-related TDP-43 encephalopathy. And we know that this worsens disease trajectory. So patients with late comorbidity have a more aggressive clinical trajectory. And indeed, we saw that non-late or late cases versus non-late cases had a lower amygdala and hippocampus volume. And this was controlled for co-pathologies. And in the amygdala specifically, this association was driven by TDP-43 accumulation. And And then another colleague, Maud Bouwman, looked in a detailed manner at the hippocampus. She manually segmented all the subfields, a lot of work, but if you do this, you get a higher sensitivity when you associate with volume, because here we see, for instance, that a increase in CDR score, so a higher cognitive decline rate, is associates with volume only in the subiculum and the entorhinal cortex, and not in the full hippocampus, meaning you get a little bit more sensitivity if you parse out these different subfields. Then a PhD student in the lab, now a postdoc at the NIH, was very interested in structural network disruptions in neurodegenerative diseases, because we know that the pathology hampers these structural networks and creates vulnerable brain hubs. And she looked at this using diffusion MRI, which he then used probabilistic tractography and graph theory to analyze these structural networks. And what she found was a decreased integration and decreased brain resiliency in the brain, specifically in the parahippocampal and anterior insula. These network disruptions weren't associated with local pathology, but rather with global alpha-synuclein pathology. And we're now currently still looking into this association. And then another colleague of mine, Shenpei Lin, looked at the monoaminergic and cholinergic nuclei in the brain and their projections, which we know degenerate in AD and other neurodegenerative diseases. And indeed, in the nucleus basalis of Meinert, substantia nigra and locus ceruleus, as you can see in the images, we see a loss of nuclei. And then importantly, we also saw a fiber tract integrity loss, specifically from the MBM to the temporal lobe. And this cholinergic cell density and fiber tract integrity had then an association, but this was also associated to cognitive decline, which we could only parse out through our multimodal approach. And then quickly for future perspectives, of course we want to go into more advanced MRI. We're currently looking at NODI measures and AI-driven approaches. Of course we're using novel pathological markers, interneuronal synapses, and for FTD very relevant TMM106 beta. And then very interesting with the University of Amsterdam, we're doing a whole brain histology. Here in this image you can see amyloid beta in red and p-tau in green accumulating throughout the brain. This is very insightful for spatial accumulation research. And then we also want to, together with UPenn, directly connect our ex vivo, in situ, and histological measures. So concluding remarks, I hope I convinced you that we have a multimodal disease approach that allows us to research several scales of several domains within the neuroscience, including structural, network, modulatory, and pathology scales. And then finally, I want to ask all the funders, the collaborators, and you for listening, and most importantly, the brain donors and next of kin, without whom this research wouldn't be possible. Thank you. I would then like to invite the final speaker, Douglas Glasgow from the UCSD.
Thank you very much. So I'm going to talk about a different kind of correlations between a set of CSF biomarkers and autopsy. And this is done with a number of co-authors, the majority of which are from the Neurochemistry Laboratory in Amsterdam. These are disclosures. And just to set the background for this work, it originates with the idea that there's a lot more going on besides amyloid and tau, and that by doing some sorts of proteomic profiling, we can learn across different neurodegenerative dementias And this particular study originated from work done that was published by Marta del Campo in 2022 using 11 different O-link panels. This seems kind of ancient. These were 92 item O-link panels at the time, and clearly there are more highly dense ways of probing the proteome. But anyway, this looked at people who were clinically and biomarker characterized, control, MCI, AD, non-AD, and differential protein abundance was looked at, and a custom set of multiplex PEA assays were developed to address questions of could we differentiate Alzheimer from control and then Alzheimer from non-Alzheimer dementias. So a similar study was done looking at people who were amyloid positive versus amyloid negative, again by CSF, during a pre-symptomatic stage. And again, the same sets of biomarkers were probed, and there was some overlap with proteins that were found in the comparison of MCI and AD versus controls. Relatively small overlap, but some pathways did overlap. In particular, proteolysis and immune function had at least similar kinds of markers with some overlap. And so in the original study, a small AD-specific biomarker panel was developed. In fact, there were two panels, one to identify Alzheimer's disease versus controls, and this is in the middle box, and you can see the names of the different proteins that were selected. For AD versus non-Alzheimer's disease, a number of different proteins. So again, some of this is handicapped by what actually went into the panels. There are no synaptic biomarkers in here because in part the O-link panels didn't include a number of really promising ones at that stage. Nevertheless, in the original study, there was, if one combined these in a linear regression model, there was very high sensitivity to be able to distinguish Alzheimer's from controls, and reasonable sensitivity for Alzheimer's versus non-Alzheimer dementia. So we wanted to re-explore this in an independent cohort, and this is a cohort of CSF samples from research participants at the UCSD Shiny Marcos Alzheimer's Research Center. And for this particular study, we selected controls, people with MCI due to AD, people with mild Alzheimer's disease, and people who had a number of non-AD dementias. And this was shown at a poster on Sunday. And so just to summarize the main results, a multiplex set of PEA assays were developed using the panels that I had shown previously, and the diagnostic panel did a good job of discriminating MCI or mild AD from controls with an excellent AUC, fairly similar to the prior study. In the differential diagnostic panel, there was pretty good discrimination of AD versus non-AD. So what I'm going to talk about today is that we've had the opportunity to continue to follow these people, and we have autopsy follow-up in 53 participants, all of whom have undergone a standardized neuropathological brain assessment. And the question is, it's very hard to get someone who has an LP and then dies while they are cognitively normal. So how does one go about assessing controls? We looked at 100 of the controls who were AD-CSF biomarker negative and actually were cognitively normal at least 1 year after the LP. And there may be other ways of trying to improve on this, but I'll show you what some of the results look like. In the autopsy sub-cohort then, we had 110 controls, 20 people who had predominant AD pathology, 29 with other AD pathology, and you can see the distribution by age at LP, sex, mini-mental scores. The AD group had a mean mini-mental of 24, other pathology 26, so relatively mild. CSF AD biomarker positivity. A percentage of the people with other pathologies did have positive AD CSF biomarkers. And so one of the big questions in this type of study is when we get someone's brain, there are often more than one pathology present. So in our basic analyses, we looked at the dominant pathology, but life gets very complicated once you start to look at presence of comorbid pathology like synuclein and TDP43. And I haven't included CAA in this particular slide, but here you can see that of the ADs, 41% had so-called pure AD, so a minority. Most had something else. We had a fair number of people with DLB as the dominant sort of clinical pathological entity, but very rarely pure DLB. PSP and corticobasal, a small number of cases that was relatively pure, one case of late that actually had intermediate AD pathology, and so forth. So there are different ways of putting this together. So this was an initial comparison of AD versus other pathology. And one can see here that many proteins in this panel are upregulated in AD, and there was pretty good discriminative performance. ITGB2 would be one of them that looked as though there was quite a lot of promise. But what's interesting here is, what about the normals? If we include them as well, I think it gives a better perspective on directionality. So here you can see that some markers seem to increase in both AD and in non-AD dementia. Some seem to be more prominently increased in AD, and I think including this type of normal cohort can be useful. There's a lot of variability in the normals, and one can imagine in future work trying to come up with the most perfect normals imaginable who are screened carefully for any other pathological biomarkers. If we looked at a number of different kinds of pathologies, so this gets a bit complicated. One observation is that, for example, ITGB2 still seems to stand out in AD. There are some people with DLB who are higher. We haven't matched this up yet with the people who had co-pathology, but that is something that I'm planning to do, is to color code people according to some of the pathological combinations. If we looked at the differential diagnostic panel, again, this did pretty well to separate AD as the dominant pathology versus non-AD as a dominant pathology, but with the caveat that there can be some overlap. ITGB2 is a member of both panels. ENO2 is neuronal enolase, for example, and that was one of the stronger predictors. Some biomarkers in this panel don't seem to be performing very well, and again, we're going to revisit how to try to combine them and what else could be added. Again, if we throw in the amyloid negative controls as a reference, we see that this gives, again, a picture of what seems to go up in AD, what seems to not go up much in other pathologies. So the ENO2, for example, is overlapping a lot with normals. ITGB2 seems to be somewhat more influenced by AD than by non-AD pathologies. And if we split this by individual pathologies, one gets a very complicated breakdown, but you get an idea that some things are a bit more relevant to AD than to non-AD pathologies. One other comparison we can make, which sort of replicates previous finding, is DDC, dopamine decarboxylase, is an interesting synuclein-related marker, and we were able to show that it was increased in people who had some degree of Lewy body pathology, and this was much more likely in people who had limbic or neocortical. So this is a summary of what happened if we kind of look at all of these different markers across both panels, and the first would be to take cognitively unimpaired amyloid positive versus negative from the 2024 publication, and these are some of the markers that showed up. And now, if we look at MCI or mild AD from the original publication, a lot of markers were highly significant. Now, when we look at different kinds of neuropathology in the autopsy series, we can see that some of the markers, some of these are relevant to neuroinflammation, ITGB2, MMP10, SDC4, for example. ENO2 is a more neuronal marker, and so not that many are related to thal amyloid, but VEGFR and DDC seem to have some relationship, whereas other markers don't. So in summary, these are I think these are interesting findings. It's remarkable to be able to do something with a relatively small set of autopsies of about 50 patients, and we're going to carry on this type of work, and I would encourage people who have CSF from people who've eventually come to autopsy, please let me know, because it would be wonderful to do some sorts of larger scale collaborative analyses to really try and understand how multiple pathologies contribute to Alzheimer's and how we can track all of this. So these are the conclusions. The pre-selected panels seem to work even in this relatively small autopsy series. DDC relates to DLB pathology. We didn't find any particular biomarkers that related to 4R tau or to TDP43 pathology, but the numbers were small. Including the amyloid negative controls, I think was a very helpful step. And again, trying to come up with the best controls possible will be helpful in future. And we hope to scale up. So thank you very much. And we're grateful to everybody, all of the study participants and to the funders.
Thank you to all presenters. And now this session is open for discussion. Please.
So while you are walking over to the microphone, perhaps you can start with, I think, an easy question, but I was very curious for Emma, because you showed some indications that you saw male to female differences in your tau accumulation, and regarding age, and we know what the onset is for between female and male, and the age at death. Do you think this is mediated by age, the difference, or is it truly a sex difference?
Yeah, so I also performed analysis in which I correct for the other variable, and they all remain significant. So there's some overlap there, but it's also an independent effect.
Perfect. And mic 1.
Hi. Well, thanks for all your wonderful presentations in the last day AIC. And I have questions from my friend, Dr. Zhibo Wang from Capital Medical University, and who is still online now. And he wants to ask Dr. Coomans about why does the tau PET positive rate decrease in the elderly and men among the symptom patients, and what is the reason behind this? Thank you.
Yeah, so the reason for the decline in tau PET positivity at older age is probably because they have less tangles in the brain. And because they have less tangles in the brain, it's probably that the PET detection threshold is not reached. So there are tangles in the brain, but not a lot. Oh, sorry about that. But not a lot. And I think it just doesn't cross that PET detection threshold. So in the end, tau PET is a really good marker for the density of tangles in the brain. Yeah.
Thank you so much.
Mic 1. Yeah.
Thank you. Thank you very much for the presentations. I have a question for Dr. Galasco. I was wondering if you were thinking about exploring other platforms like SomaLogic or NuLISA for analyzing the proteomics data.
Sorry, this is not sure if this is what. So certainly we are thinking about exploring other platforms, including also mass spectrometry to try and identify markers. I think given the CSF is a relatively precious resource, it is nice that for some of these platforms and multiplex markers, a relatively small volume is needed. I think one of the challenges is coming up with enough autopsy material that you are covering a full spectrum of disease, and then enough that you can try and somehow deal with co-pathology in a good way.
Thank you.
So maybe before we go to mic number 6, we can do an online question. This one is for Samatia Karagiani. Thanks for the amazing presentation. There are 30% of people older than 80 years that will have positive amyloid PET just for the age. How about p-tau 217? How it changes with the age? And also that could be a reason for false positive, question mark.
Oh. Is it open? Hello again. So we have seen basically that p-tau, I mean, of course we have the master next to you, so he knows even better, that with age it goes up, so increases. So indeed, I would expect that. Also, our sample, so it starts from 50 years old and has maximum 94 in ADNI, and you have an average of 73, I think. So that could indeed explain, I would say, this. And yeah, so also at this point we are doing, it was already presented on Tuesday, a longitudinal reads of tau. And also we used the plasma, but yeah, this one was the mesoscale one, not the lumipulse. And you can see that indeed, as you go with the age, it's interesting, I would say.
I could just comment that perhaps we should be careful with false positives, because if it's indeed so that age increases the risk of amyloid onset, that is obvious, of course. And then phospho-tau, if it correctly identifies amyloid plaque pathology and older, then it's not a false positive. But there have been presentations in this meeting and also earlier this year indicating that the noisiness of phospho-tau 217 is a great marker, but the noisiness increases with age in an amyloid-independent manner also. So age will be an important factor to take into account, but not as difficult as for NFL, for example. It's a much stronger relationship with amyloid pathology than with age for phospho-tau, I would say. Should we go there?
Yeah, mic number 6, please.
Thank you for this wonderful panel. I have a question to Niels, and I think it was your work on myelin. And I saw in the protocol that you had also magnetization transfer ratio scans available. Did you happen to compare them to the T1, T2 ratio, and whether you would be able to compare both of them to histopathological stainings of myelin?
Very good question, because that was the initial aim to also look at MTR. We didn't see a lot in MTR in our first assessment. I think we need to parse it out a little bit more. And also we saw quite a lot in the T1, T2 ratio. So we decided to focus on this, but we will definitely revisit the MTR. Thank you.
And a quick follow-up, if I may. Do you have multi-echo gradient echo scans in these in the protocol available? No.
No.
Okay.
But we're going to a new MRI scanner, so perhaps we should talk about what to include and what not to include.
Thank you very much.
Mike 1.
Hi, I'm Floorduis from Amsterdam, and actually I have a question for Emma, my colleague, because I'm now, as a neurologist, disclosing tau PET results to my patients, and sometimes I struggle with it, and maybe it's partly due to what you showed. So would you think it's better to have a lower threshold of tau positivity of a tau PET, because it's only positive in BRCA5/6, so sometimes I get negative tau PET results back, and I think, how is this possible?
Yeah, I've thought about this a lot. If we lower the tau PET threshold, then you also lower the specificity and the positive predictive value. It's now it's 100% now for detecting BRCA5/6 pathology. And I think it's just something on how to interpret tau PET. I think in the end, the SUVR values that we have, it's a very good correspondence for the density of the tangles, and not necessarily, it's a better measure of how many tangles there are, and maybe a bit less on where the tangles are located, which is the BRCA staging system, right? Because someone can be BRCA5 with only a single tangle being present. So I think in the end we have to think about tau PET as a measure for tangle densities in the brain. And if you are below the threshold, you can have tangles, but just not a lot.
So maybe we have to have a more nuanced interpretation, continuous.
Yeah, so I guess a positive tau PET scan really corresponds to the presence of BRCA5/6 pathology, but a negative tau PET scan, it's more that there's a low amount of tangles in the brain. It can still be present, but the density is low. Yeah. That's how I would view it. Yeah.
If I may, I want to relate this type of question to one other panel member. So Sakbin Lim, you showed that, which for me was very interesting, that just by using the tau PET a little bit different, you could differentiate different kind of tau isoforms, and perhaps gain a little bit in earlier pathological stages. But I saw, or perhaps you could comment at this, the specificity was also a little bit changed, and also I don't know how, or perhaps you could comment on how good it would be to still differentiate between these BRCA stages, because it seemed to overlap a little bit.
I would like to make sure that your question, are you asking about some kind of threshold point?
Yeah, basically.
Yeah, for in my study, when I calculate the overlap index image, I used the 1.3 threshold for the SUVR values. However, when I try the 1.2 or 1.4, there is no, if I set the 1.4 threshold, there is no many cluster map for calculating overlap index. However, when I try to set the 1.2 value, there are many cluster map to get the overlap index. So I have to optimize optimal threshold value for that. So I choose the 1.3 value. So I think that is the depend on the data set. So I think we have to set the threshold very carefully. Yeah.
And do you think, for instance, Emma could use your OI outcome measurements? Would you recommend this, or
About the value?
about better sensitivity in lower Bragg stages, basically?
I think in my case, 1.29 and 1.3 value is a raw limitation about the SVR threshold, I think. Yeah.
Okay.
Mike two.
Mike,
I want to congratulate everybody. Melissa Murray, Mayo Clinic, two of my favorite things, neuropathology and biomarkers. Dr. O, you did something that I thought was really interesting, and if we have time, I would be interested in others commenting. You highlighted what was difficult, and you highlighted what slowed down the project and what you learned. And I think so often when we're writing papers, we don't get a chance to highlight how to save somebody else time. In your papers, do you have a chance in like the supplemental to talk about what took so long? And is this something we do in plasma world? I don't actually know if I've come across it as succinctly.
Yeah, I mean, thanks for the questions. We would add a lot more detail in the supplemental, especially for the methodology part. I think Niels have some common experience like I do, especially comparing histological image to neuroimaging. Registration is very difficult, depends on your specific protocol. And for my case, is really how to transition your histological image to in vivo image, regardless of the time gaps that you're having. So that could be very tedious in doing. And also, something that I want to add on to one of the panelists, also from Mayo Clinic here, is that you shows the way that you quantify the tau in neuroimage is actually correlating to 4 repeated tauopathy, right? Which is exactly the opposite of what I found. But of course, we're using a different way to quantifying it. So I wonder, would you promote your way to quantify it and make photoscopy as a method to quantify 4 repeated tau as well?
Thank you for your question. I think the way I calculate based on the tau pad over index is showing the spatial consistency to quantify the tau distribution in the tau pad. So I think that is quite little different about the SVR scale value. So I think the 4 tau peri, in my case, there is no any powerful SVR value in the region or in the individual tau pad. However, over index method, it can possible to sense the tau spatial consistency over threshold 1.3. So in the gray matter as well, in the white matter, in some white matter area. So I think that over index method is possible to capture some tau signal in the 4 tau pairs.
Yeah, I'm interested in using your index to maybe run the analysis again and see if I can see a better correlation with the 4 repeated tau, because I'm using like a 1.2, so even lower, right?
Yeah.
But yeah, for the SUVR method that I'm quantifying, it's not showing. If I may, I have another question for Neil. So I think it's one of the study that your colleague did, but when you're comparing the volumetric difference between the histology LC versus the MRI LC, do you see the volumetric decrease is correlating with the histology between the MRI?
It's very hard to quantify the volume carefully because it's such small nuclei. I believe in that study we focused more on the integrity measures. So it was DWI and measures. So we mainly looked at that. I'm out of the top of my head, I'm not sure what volume did there, but we saw a lower density in these nuclei. Yeah.
Thank you.
Now we have gotten several questions here online. To Stam, what about looking at the percent of phosphorylated versus non-phosphorylated tau at amino acid 217? I don't understand why we don't look at this more. Using the beta 42/40 ratio makes so much sense. Would you like to comment?
Thanks for the question. And I had a discussion recently that I thought that it's really bad to say that I don't know, because I'm not doing wet lab. So I would unfortunately say that I don't know, because I'm not working that much like with details about plasma biomarkers. I'm more like about the others. So maybe you can comment
I
on
could
this.
just comment quickly and say that the different assays we're using, the immunoassays that are measuring absolute concentrations of phospho-tau 217, if you take such data and ratio it with plasma total tau, that destroys the whole thing. Because then you have peripheral tau that is 80% of the signal messing up the so it doesn't, but I agree with the person who don't know who it is, who asks the question, that it's interesting to compare with the beta 42/40. With mass spec-based assays, you can, in the same sort of analysis, get data on the phosphorylated tryptic fragment incorporating amino acid 217 and the non-phosphorylated. And this is the ratio that is discussed a lot, and it's part of many of the presentations from the WashU group and also C2N. And that ratio works really, really well to pinpoint amyloid-related tau phosphorylation. It becomes problematic if the patient has other causes of neurodegeneration that brings up the general tau level in CSF and plasma. So if the patient has had a recent transient ischemic attack or a brain trauma, or if there are other neurodegenerative changes kicking in, then the ratio bends off. Then, so it is not, I think we always should look at, irrespective of the technique, both the concentration and look at the components of a ratio. And then you can look at the ratio. So then you maximize the information you get from these biomarkers. So it's a little bit of a vague reply from me also, but so I could look at both, but there are some dangers with looking at the ratio incorporating tau. A-beta 42/40 makes more sense because we don't know of anything that is pathologically disturbing A-beta 40 actually. So that is sort of in that ratio used as a normalizer for amyloidogenic APP processing, making the A-beta 42/40 ratio work better than A-beta 42 alone in both CSF and plasma.
Just to remind the audience, we have 15 minutes left, so more than enough time left to ask questions. You can also post them online. In the meanwhile, I have a question still for Yuang Chen. So since you showed this importance of iron, and I agree with you, I think iron is a very important marker to look at. But also this associates very well with certain cell types. So are you meaning to look, for instance, at oligodendrocytes, which we also found very interesting and relevant within our cases? So the question basically is, are you moving also towards cell type specific research?
Yeah, so actually two of colleagues is doing cell type research, not specifically for the oligodendrocyte, but they are looking into, actually Grace is like right here, for the selective vulnerability of the sleep-wake cycle of comparing amyloid and tau to the specific nuclei in that way. And they're using our pipeline with some modifications, so that's been showing some promising result. And for the iron itself, and I agree, there are a lot of relationship between how the iron-tau interaction. And I think the main point for my study is not to like directly quantifying iron in photosophy, because after all, photosophy is not designed to bind iron, but just an indication of target binding. So I think in that end, I'm moving on to QSM MRI that is more designed for quantifying iron, and we are also doing on that end. And you're bringing up a very nice point of staining for like oligodendrocyte specifically, and then link it back to QSM MRI to validate its capability, which I would definitely add to that ongoing project. So thank you.
Thank you. Mic number one.
Amazing work, everyone. I also have a question to the fourth speaker. So it may be basic, but is the iron binding also specific only to fluorotaucipir tracer?
I only work with. Sorry, are you asking like if iron only bind to?
Is it also like common in other tau PET tracers?
So we have a second generation, tau pad like the MK. I think on those it's showing a less amount of off-target binding. I haven't do correlation analysis between the histology to those newer marker, which I would be very interested in doing. Anyone has the funding, please find me. But yeah, I can only speak for taucipir at the moment. So.
And then a follow-up question. So we know by now that iron is also very elevated when there is more alpha-synuclein pathology. So in case we would now study, let's say, tau pathology in Alzheimer's disease, and we know that alpha-synuclein pathology is also often present, can it be problematic then that when we're looking at specific regions where we know that there is elevated iron with alpha-synuclein, that we're actually having this confounding issue when investigating tau pathology?
Yeah, and that's why this voxel-to-voxel correlation is so important. We are not just estimated regional amount, but we are really looking at the best resolution is possible for the current available neuroimaging. And that's why we are seeing in like PSP, like basal ganglia, we have iron, we have phosphorylated tau in a like a regional sense. But when we are really dive into the resolution-wise, in voxel-to-voxel, we do see a difference between the correlation between phosphorylated tau to taucipir in PSP or MAPT comparing to iron. So that's how we can tell if we are seeing the true signal or not, is to get into more refined resolution comparison.
Okay, looking forward for the QSM study.
Yeah, thank you.
Could I just make a comment in this context? Now I will perhaps complicate matters further, but iron induces tau phosphorylation. So if you have patients, for example, with superficial CSF siderosis, their CSF levels of phospho-tau are as Alzheimer's. And if you find the bleed source and fix it by neurosurgery, then phospho-tau levels go down. So perhaps we should start a project looking at this carefully, counting microbleeds relating to fluid-based phospho-tau signal. And it could also thinking about CTE, for example, the perivascular tau deposits in CTE, they also are iron positive. So this probably is not only a problem, but mechanistically interesting. Oh, now hey, okay, please, mic 2.
Hi, Matthew Kang from Melbourne, Australia. Thank you everyone for such a great session. My question was for, hopefully I'm not pronouncing this wrong, Stamisha from Gothenburg. Did you find any sort of sex or age differences in the cognitive, in the performances PTR217 in the cognitively unimpaired A+ groups? Like some of the other speakers sort of alluded to some characteristic differences there.
At least for this, we didn't look at this because the point was totally different, but it would be really interesting, to be honest, to check, because all the time, you know, we see this kind of relations, and we saw this also in other presentations, so I think it would be really interesting, but no, I don't have any insight for now.
Okay, thank you.
We have a question from online for Emma Kongans. Wonderful presentation. In the autopsy to PET data, do you have amyloid data, and are you planning on analyzing it?
Yeah, no, we don't have any amyloid PET data. No, we have amyloid postmortem, but not in vivo.
Okay, thank you.
No.
I have a question for you, Niels.
Yes.
Yes. When you showed the volume changes related to amyloid, do you think those are of relevance when you interpret the, or if one could discuss it in relation to the volume changes seen after amyloid removal by antibodies?
Yeah, that's a difficult question, which I asked a lot of people as well. Some of my collaborators also think shrinkage, which is negative. But yeah, we're very curious to look further into the inflammatory panel and see what's there going on, if it's a mediated effect. Yeah, the swelling is definitely interesting, but I also thought, which is also has some critique, was actually coined by Irene Frigerio, who also published on it, found the same increase, this time in thickness, who thought it might be a space-occupying process of the amyloid plaques. I think this also had some critiques, but definitely important to look at. We have another question. Oh, that's one. Let's go to this one. Another one for Emma. In the A16 autopsy cohort, there's no MRI available for quantification. Do you think this may have influenced your sensitivity to detect BRAC 5 to 6? Do you check whether your negative cases on quantification were positive on visual read?
Yeah, so I should have actually included that in the presentation. The Eli Lilly A16 study does not have an MRI. We do, so there was this previous paper by Freiburg-Haus et al. From Lund University. They created this method using, transforming the PET scan to MNI space and then projecting the ROIs back to subject space using the MNI transformations. They also used a threshold of 1.36 SUVR to define tau PET positivity based on this method. And it looks quite nice. I don't think we, due to this, there would be anything that we wouldn't expect, actually. The images, it corresponds very well with how we would view the images. Yeah.
Okay.
Can I ask Doug a question? The DDC findings, Doug, they look really exciting, I think. Do treatments with levodopa or so, do they influence DDC concentrations?
We had very few people at the time of LP who were receiving treatment. And I think it was an N of about 2 out of the 14 DLB patients. When I took a quick look, there wasn't any particular effect. We would need to look in the overall bigger series of living patients to be able to come up with a stronger idea of how much DDC seems to be influenced in CSF by treatment. I mean, other papers have suggested that there's a very small or limited effect, but plasma somehow suffers more.
Thanks. Ashwini Maitri.
Springboarding off of that treatment effect question, but taking it back perhaps a little bit, and this is outside of the scope of the work presented, but whether you know about any such changes seen in people with prodromal forms like idiopathic REM-BD, where they may be treatment naive to L-DOPA but might be treated with something like pregabalin instead, whether you've seen DDC changes, and also how it performs against CSF alpha syn RT-QuIC, whether there's a kind of really good correlation, because I think CSF DDC might be kind of more generalizable in terms of measurement in labs in different places.
Right, so we have some RT-QuIC data in the series, and I'm trying to extend it so that we will be able to come up with that sort of comparison. At the moment, I can't give you a clear answer. I mean, one of the other, in principle, one of the things DDC might help with is prognosis, because it's going to be quantitative, whereas at the moment RT-QuIC is binary. And so maybe next year we'll show some of that data.
And not anything obvious jumping out from prodromal forms like REM-BD in terms of the evidence for treatment-naive patients having elevated DDC?
Yeah, we'll have to see. I mean, there are data emerging from a couple of other studies looking at idiopathic RBD, where at the very least there is CSF. DDC, to my knowledge, hasn't been measured by a good assay in some of those cohorts, but some of those data will be available probably before the end of the year.
Thanks so much.
Sorry.
Quick question, Doug, along these lines. Have you tried just ignoring the clinical diagnosis and say who is above a certain threshold of Lewy bodies and who is above a certain threshold for other pathological features, and just compared everything else to to those and see if there's one marker that seems to stick out for each of the pathologies?
So we've taken, I've taken a preliminary look at that, and again, this is a small series. So I did a previous study looking at different forms of p-tau and NFL in plasma against autopsy with a relatively short gap of 2 years or less. And it seemed that people at TDP43 didn't have anything, again, among the phospho-taus or neurofilament light or one or two other markers that stood out. I think with a very large CSF proteomic panel and enough people with TDP pathology, we might see something. But I think one of the problems is if you have TDP pathology and concomitant AD, I think the signal of change, the amount of change AD causes in so many of these other markers makes it hard to see something else as a background. I think in the best of all worlds, it's nice to have relatively pure cases and then try and figure out how to decompose in the mixed cases.
And then we have the final question, I think, from online, which is to my presentation